just came out in the journal Pediatric Orthopaedics. Ted's probably not here today. Looks like I'm on my own.
He's in Hawaii. He's on vacation.
He's in Hawaii. Okay. Well, I can say what I like about that paper. The building block today, as far as your research infrastructure skills, is interaction with the Office of Sponsored Programs. And the main event today is Beth Hacker, who is a research navigator for the Institute of Translational Health Sciences. And Beth's going to tell you what you need to know about and what ITHS can do for you in your research endeavors. So, Emily?
Yeah, Dr. Kavanaugh just wanted me to let you guys know about the very convenient resource that we have. If there's any studies that you guys are involved in or thinking about doing, or if you have any ideas that might involve MRIs of anything, I'm doing MRIs of cadavers, I do animals and humans also. There are 2 MRI scanners at the U that are dedicated solely to research, and if you have enough money for them, they are very, very convenient. So they're down in the basement, and basically you just go to their website and there's a contact person. You fill out a form about what you want to do, and then you'll meet with one of their scientists down there. They'll help you come up with a protocol, and then you just sign up on their online schedule for whenever you want to do your scans, and you can do them. I think the website is, I think it's departments.washington.edu/MRlab, and then all the information is there. But I think it's about, it's not cheap, so you do need money for it. It's $600 an hour, but I was able to scan 6 or 7 cadaver MRIs in 2 hours for the study that I'm doing, and it's very easy. And I think I contacted them after I contacted them, I had all my MRIs done like a month or 2 later. So if you have any questions, you can let me know. I can email everyone the website, but I didn't know that it existed, and it made what was going to be the hardest part of my study very, very easy.
Of course, the actual hardest part of your study will be segmenting the MRs, and I want to add that some of you had experience with this. We have a program called Simpleware, which enables us to what's called segment the MRs. So you go slice by slice, and you can acquire a digital representation of structures on your image. It's semi-automatic rather than automatic. It would be nice if you could just set a density and just acquire all the voxels in the whole stack that were of that density and representing a bone image that you wanted. But in practice, it's not so straightforward as that. You've got to actually go slice by slice. But you end up with a fantastic model, a really great surface model or volume model of your structure. All right, let's take a quick look at this paper. It came out in the Journal of Pediatric Orthopaedics. The co-authors with Ted were Vivian Von Padre and Clayne White. This journal has an impact factor of 1.163. That's very low impact factor, but you are aware, of course, that impact factors are very subspecialty dependent, and pediatric orthopedics is a very small field. You're never going to have a 32 impact factor journal in that field. You all know about osteogenesis imperfecta. It is a rare disease. The best known estimate is that there's a minimum of 20,000 and possibly as many as 50,000 cases in the US. There are 2 major types. We'll talk about classification in a minute, but in the dominant type, the individual has either too little type 1 collagen or a poor quality type 1 collagen caused by a mutation of the genes that generate type 1 collagen. In the other kind, recessive, the mutations are in other genes which interfere with collagen production. There's an NIH website on the general information page, and it is a rare disease in the Office of Rare Diseases Research. So that's another place you can go to get information about it. Now, intravenous pamidronate, widely used in Paget's disease, is a first-generation bisphosphonate, Aradia, and it's been used off-label for the past 20 years for the treatment of osteogenesis imperfecta. And although it is well known that there are bone density increases, there are no studies of functional outcome using, that should say, validated measures. This group hypothesized that there would be deficits before and improvements after treatment with pamidronate as measured using a validated pediatric outcome data collection instrument, which is well used and validated in the literature. There is a more detailed classification for OI. Here it is. There are at least 7 types that have been identified. It used to be that OI was classified phenotypically, but now there are overlays of the inheritance pattern, as you see, and there are some clear phenotypes, mostly depending upon the hearing deficit, the color of the sclera, the number of fractures, whether they're fractures prenatal or postnatal, and there are a number of other classifications that have been added. So this was a retrospective registry review. There is a registry at Children's called the Skeletal Dysplasia Clinical Registry, and in this registry the intent was that the PODCI, this outcome instrument, be administered once a year or at any time there was a surgical event. The form of data collection is the parents' report for children aged 2 to 10, and it's self-report and a parent report for older children. You can look at the individual questions here. It's an open access, not a pay-for-play instrument. There are these 6 domains that are measured, and the one that we will be focusing on today is the sports and physical functioning. That's the one that turned out to be interesting in this study, where there's a difficulty or there are limitations encountered in participating in more active activities and sports. So of the subjects, and I think it was 51, yes, of the 51 subjects that were in this registry, half of them were wiped out for various exclusions: misdiagnosis, treatment elsewhere, the form had not been completed, and they had less than 1 year follow-up. The data that were extracted are shown here. These were all extracted from the record. Now, further, after these 26 patients were excluded and 25 were included, they were classified as 10 patients with mild disease, less than 2 fractures a year, and none of these cases were offered pamidronate. There were 5 males and 5 females with an average of 9.5 years. And the 15 patients with severe disease, greater than 2 fractures per year, they all accepted pamidronate therapy. And they had the dose shown here according to an accepted protocol. And there were 9 males and 6 females with an average of 10.2 years. The silence classification that we mentioned earlier is shown here. There were fairly broad distribution of the silence criterion. In fact, as we shall see, these authors suggested that from an orthopedic point of view, this silence criteria is really not very useful, and that you can stay with the severe, less than 2 fractures a year, and greater than 2 fractures a year as a more functional classification for orthopedics. The average time to follow up from the very first time this inventory was completed was 440 days for the mild and 886 days for the severe. And you can see there's a huge 1 year-ish standard deviation for that. And there were no significant differences in the height and weight of the kids at entry. However, the group that was treated with pamidronate, they significantly increased their height and their DEXA only if you look at whole body score. So there was no significant difference, although you see there is a change, but there was a large variance in the spine, in the hip, in the distal femur. But when all of those were combined into the total body Z-score, there was, these are Z-scores, how far down they are in their DEXAs. You can see there was a significant bump up as you'd expect. So the treatment was effective in achieving height growth and gain in total body BMD. The only domain of the PODCI that was significant was this change prior to treatment, post-treatment in the sports and physical functioning domain. And you can see that, by the way, this score is 0 low functioning, 100 maximal functioning, that the mild cases were 82 before and the severe were 45 before. After treatment, this score went from 47 to 57. The reason those numbers are different is that only 11 of the 15 subjects had an available score afterwards. So the changes in the mild group, these results were rather compromised by the fact that only 4 of the 10 mild subjects had a second instrument available. Now, I think this is really an important point for you, particularly when you work at children's, to realize that it's really important, if there's a protocol in place with one of these registries, for you to know everything about that protocol and make sure you complete it. Because this really limits what could be said in a comparison of the mild and the severe group. Because the treatment group increased in height. Well, what component of that height was gained just because of increased age? And what component of height was gained from the pomegranate? We'll really never know, because less than half of the mild cases had that inventory filled in. So when you rotate into a service where there's an ongoing study, it's really important for you to find out what the protocols are and to complete those protocols. With the data that they had, they found no significant changes in either height or BMD, but of course it's a limited sample. So here are their conclusions. Pomegranate increased BMD. Physical functioning is diminished in children with more severe disease. Pomegranate therapy is accompanied by functional improvement. Now, this contrasts with another study where children were treated with oral bisphosphonates, and they did not show the same physical improvement. And as I mentioned, the authors felt that this silence classification was not very helpful in an orthopedic context. So what about the limitations of the study? Fred, can you hear me? Aloha out there, Ted in Hawaii. Small sample, but of course this is a rare disease. You're never going to have 200 patients in an OI study because there just aren't that many patients around. We've dwelled already on the incomplete assessment of the mild group, and that put a bit of a damper on the comparison that could be made. There was no severity matched control group, so there was no severe cases who were not offered pomegranate. And there's a discussion in the paper that perhaps that will never happen, a randomized control study, because it seems the pomegranate is so effective that it is no longer ethical to withhold that from kids with severe OI. They don't mention side effects, and pomegranate is known for side effects, bone pain, low calcium levels, nausea, dizziness. There has been a great debate in the literature about osteonecrosis of the jaw, mostly in cancer patients, but there's not a discussion of any side effects in the paper. All right, so that's this month's paper. Any comments? Okay, then let's move on, and the second part I briefly want to talk to you about interactions with the Office of Sponsored Programs. So this is the office in the university that is responsible for moving all proposals that have a financial component to them, and some others that don't, but those are on a case-by-case basis. But all grant proposals that you will submit as a resident have to go out through the Office of Sponsored Programs. Now, I want to go first to the important things, and then we'll come back to the implementation. It's critical for you to know that the OSP is the only authorized office in UW that can submit a grant. So supposing you get on to, let's say, the OREF website, and you notice that they have a resident grant award, and the deadline is Wednesday, and you decide, okay, this is great, this is just what I've been waiting for, I'm going to write my grant when I'm post-call, and I'm going to submit it on Wednesday morning. That, I'm afraid, cannot happen. You may be able to do it physically, intellectually, but the university has a really rigorous and absolutely immutable system whereby first the grant has to be sent out by OSP and not by you. Secondly, the grant in its completed form has to be available 10 business days before the deadline. So I have had people come to me and with the kind of scenario I just gave you, where they see a grant and it's wonderful that they have the energy to do it, but they didn't know about this, and unfortunately they just can't do it. You cannot squeeze a grant out of this university in less than 10 days. Nobody can. I tried to do it and got severe rapping on the knuckles. And it just isn't possible. It goes like all the way up the line, and they finally say, no, I'm sorry. So that's my biggest message here today. Look for your grant opportunities early. Come and see Teresa and I about it as soon as you can, and we will do the submission, we'll manage the submission for you. Now, an EGC1 has to be submitted for every grant. Now, what is an EGC1? Everything goes through SAGE, the system to administer grants electronically, and in fact, almost every interaction you have with OSP is generally electronic. Sometimes you talk to a person, but what happens is this, and I'll just show you very briefly, is you go to this website, which is depicted here, I hope, there we go. And you sign in with your UID. Now, this, I'm already signed in. To have access to this website, Tom Zorich in our research accounting office have to have given you permission to be a qualified user. Now, there's a huge hitch here in the School of Medicine. Even though OSP, the Office of Sponsored Programs, says it's just fine for a resident to be the PI on a grant, unfortunately, the Dean of Medicine does not agree with that. And the Dean of Medicine has decided that, unfortunately, none of you can be the actual PI of record on a grant. So for your OREF grant, that I gave you the example, somebody else on the EGC1 has to be the PI. That's likely going to be me. So nevertheless, I can give you, and Tom can give you, access to SAGE. So I will set your EGC1 up, your electronic form up, and then Tom will give you access, and you'll go in and fill all the pieces if you want to, and with my help and with Teresa's help if you don't. And so here's how it works. Look, you create a new EGC1, and you've got a variety of steps. You've got things that you fill out for, let's just say, create a standard EGC1 here. The question was really about submission through the grant wizard. So we're going to create a standard. And here it is. And these are the various sections. Look, who's going to be on the grant? What is the access you're going to give? Give them an abstract. Tell them about the budget. Any questions about cost sharing, compliance? Is recombinant DNA going to be used, or animals, humans going to be used? Some explanations of that. A summary, you can attach documents. Once you're done, you can certify and route it, and then you're off to the races. And it goes into an electronic, very nicely, actually, nicely choreographed electronic pathway. So when you will see this, most likely, is that we will help you with things like the budget. Look, here's all the budget details, and we can help you with that. We can help you with the personnel section as to who you'll have on the grant, and who else will be part of the grant with you. But you will have to prepare the meat of it. You'll have to prepare, they won't let me move until I've got a title on here. You'll have to prepare obviously the scientific part of it, and that will be attached, and then the whole thing will go forward and will be routed. So that's really as much as I want to say about OSP interactions. It's that you have to be ahead of the game, has to be done in advance. You have to have somebody who will be the PI of record for you internally. That doesn't mean they'll be the PI when the grant goes forward. That's just the PI of record internally. And that we can help you with all these interactions, but we can't help you if the deadline has passed. Any questions about that? Anything from any experiences some of you have had? Kenny?
Well, I just want to comment. The first time that I tried to submit a grant, I hit the 10-day deadline on the EGC one, and that's a huge bummer. So it's just glad that more people know about it and be reminding other people about it, because it's actually pretty easy. It's pretty helpful. And like, so my initial sense of OSP was like, oh, they're stopping me from getting to do this. But once I actually submitted a grant and saw how much work they do to help you all the rest of the way, it's actually a really nice resource. And Adrian, especially, and other people at OSP have been extremely helpful. It's more complicated than you think, and they take care of a lot of it for you. And I was so worried about the budget, it's kind of confusing. And between Carl and Teresa and everybody else, they really help you a ton with that. So you don't have to feel like you're doing it alone. I feel very well supported.
Thank you, Kenny. That's a good point. I like the system too. Kenny's right. It's very complex. You would never think that to earn $1 to do research, you have to give, you have to ask for $1.80 or $1.84, depending upon what else is there. The university takes 54% indirect costs. They take between 25 and 35% in fringe benefits, and so by the time you have your dollar to do something with, you've had to earn $1.85, and those kind of things are not intuitive, and that's why people can help you. Amy?
I just wanted to talk about the cost sharing part can be very tricky, and especially because you're working with clinicians and they have to, their time has to count, and so that also, Penny's very aware of that, that's why you need to start early, because negotiating that cost sharing, you may have an attending that you want to work with on a specific project, but they may not have the time to give to that grant, and you may need to go to someone else. So that budget piece starts very, very early.
Yes. Now, there is a little bit of slack in this 10 days, because really all OSP wants to know about is that the budget is right, the cost sharing is right, the compliance is right, and they give you a little slack in uploading your final finished massaged narrative that's actually going in to the agency. So although the 10 days is absolutely rigid, don't let it be known outside this room, but I have often submitted a totally dummy narrative, which has nothing to do with the grant I'm submitting, because they don't read it and they'll let me push and pull it up until the deadline. So get it going early, and that's going to help you learn something about that. Thank you.
Has anybody here used the ITHS at all? Okay, I just want to kind of get a feel for that. So my name is Beth Hacker, and I am indeed the navigator for the ITHS. My background is I have a doctorate in biochemistry, and then I did a postdoc in pharmacology here. And I've worked in research labs, done everything from animal work to writing scripts, the bench work, kind of everything in between. So I have an idea of what goes on at the university, what you need, what different steps there are, and interacted with things like OSP and such. So even if there's something that our group can't necessarily help you with, it's possible that I can hook you up with what you need in the campus or the region. So what is the ITHS? Well, we are like a virtual repository of expertise and services. So we are funded by the NIH through the Clinical and Translational Science Award, or the CTSA program. And this is based at over 60 academic medical centers throughout the country, with the goal of trying to move forward translational research, bringing what you guys find here at the bench or at the bedside and moving it into the working with the public in clinics. So we have experts in all sorts of different disciplines, and I'm going to go through kind of our different areas that we have. Not only here at the UW, we have people at Children's, at the Hutch, Group Health, and also throughout the region. So we aren't just based here in the Seattle area, but we are in charge of a 5-state area. So our CTSA is the only one who has such a broad mandate. So a lot of emphasis on rural health, implementation, dissemination, as well as kind of basic bench services. So as you are working on your proposals, thinking about what you want to do, we can help you navigate this path. One thing that we do is help with study design and data management. So this is biostatistics, kind of informatics type of things. So basic study design, sample design, data analysis. Also, on a higher level, we also are clinical coordinating centers for large multi-site studies that are going on. We also support REDCap. Is anybody here using REDCap? That's very popular and a very great tool. It's someone has compared it in a way to an Access database, but it's much more flexible. You can do surveys and track multi-step processes. It's great. It's free and it's HIPAA compliant. We also offer coursework, classes. Boss, our administrator, can help train you on how to use this. It's a really fabulous tool. We also, through our informatics group, have access to electronic medical records through Amalga. So this is only for UW Medical Center records. And we also have a de-identified clinical data repository where you can be trained to go and take the classes so that you can get kind of an aggregate, so do your own searches for what type of patient pools are out there. So you don't have to rely on somebody else doing that or to have an IRB or at that point to do that. So it's something that we've just offered. Yeah.
Can you explain what Amalga is?
Amalga is a way that you can search text in electronic medical records. So if you're looking for how many patients have a certain coding or how many people have diabetes, male, age 40 to 50 with these certain confounding, our informatics people can pull that out for you.
I was just gonna comment on it's something I didn't want to let everybody know, but I took the training for the DCDR, the de-identified clinical data registry. So it's actually a new way we can, instead of when an attending says, hey, go find these 150 patients that have this, this, and this, and you have to comb through the electronic records, this is a great way to identify the cohort. You get it de-identified so you don't need the IRB, and then you send them the request. And if it's something that they can find, then an IRB process starts. So if that interests somebody, we can talk further. But I've taken the training, so I have access to the database.
So yeah, if you're planning, you don't have to go through and wait for the IRB to then actually find out whether or not you have enough people to actually do your study for that. Amalga is also used for, there are a couple instances that I know of people of recruitment with specific IRB approval. So one study was looking for, it was an autism study, pregnant women who already have given birth. The kid needs to be kind of within the first child needs to be within a certain age range, and they're expecting their second, and they wanted to do a study with these families. So there's a complicated way that they can go through and search and find, and then depending on the IRB, you can send something to them to ask if they're interested in the study. So that's a little more complex than just figuring out how many people there are for that. We also provide a regulatory support and bioethics. This is a very busy group for us. Data monitoring committees. We also have a pool of trained research coordinators that can be hired on an ad hoc basis. So if you need a research coordinator to do some recruitment for you for a week and then come back 2 months later to do some kind of post-recruitment cleanup, we can do that. If you need someone to go through with a month or two, they can do that as well. This also includes skilled nursing as well. So there have been people who have trained to help their groups with phlebotomy and other more technical. Yeah.
Yes, I want to add that I have used this service, and it's fantastic. It's $28 an hour, I think, about that, which is really pretty decent. And these people are smart. They've had research experience, and they get right on the job very quick to start. So it's a very nice option, particularly when, of course, you wouldn't have a lot of time to follow up in lengthy patient contacts in a research context. Very good service.
Yeah, thank you. They also set up databases. For example, if you want to do a REDCap survey or any of those type of things, you're just like, hey, I need to survey these patients. I need to get these data points from them. Go for it. And they can do all that and make that. So, and then we also have IRB application and compliance support. A lot of people come to us and say, well, I have this kind of tricky IRB application. I'm not quite sure what to do with human subjects. We have a group of compliance people that can help with that. Or something's come back from human subjects and you're not sure how to deal with that. We can work with you on that. And as well, bioethics consults. Sometimes there are groups, people working with groups that are elderly, children. They just kind of want to run through what their protocol is before they move things forward. And we have a group of bioethicists who can help with that. Clinical research centers, the main one that we have is UW CRC over on 7, I think. Seattle Children's also has a very active pediatric clinical research center. There's a dental research center if there's anybody working with that type of thing. We also have bionutrition and body composition. This works in tandem with our clinical research center. For example, if someone is having a pharmacokinetic study and they need all their patients to be on the same diet before there's any kind of dosing and then treatment with that, the nutrition group works with the CRC in order to make that happen. There's also DEXA scanning and VO2 max type measurements there as well. And gene and cell therapy facility for anybody doing that type of work. So this is also inpatient and outpatient. Our preclinical group works with people who are developing drugs and devices. So people putting in investigational new drug applications into the FDA, people designing a new defibrillator or a pacemaker or all sorts of different things that are coming through, a lot of things through bioengineering and pharmacy and such. Also people interested in doing an animal work, preclinical animal work with that. It's a very active group. They also work in tandem with the Center for Commercialization at the University of Washington to make sure that all the intellectual property is taken care of appropriately. So those are some of the services that we have, but we also have a bunch of resources that are easily accessible as well. Our community outreach group, this is a group that works mainly out in the region, but there is quite a lot of work here done in the Seattle area. This is people focusing on work with our tribal groups, Alaska Native and American Indian, Hispanic communities throughout the area, and then clinical practices throughout the WAMI Practice Region Network. We also have a Native American Clinical Research Network that's very active also in Montana. This is very much of a dissemination and implementation group working with communities who are also interested in themselves trying to get involved in doing research for their group. We have a fabulous list of online resources that you can go and look at. So in our resource directory, we've divided up into several different key groups, such as here's analytical animal models, databases, equipment, and things like that. So if you're looking for a specific kind of microscope or want to know if there's, I heard earlier about an imaging facility or different things like that, instead of going and looking for that in all the different websites and different departments, and this is even throughout the region, you can go here to this one link, and we've already done all that work for you. click on it and it tells where the resource is and then any other information that's particular to that place. Also, if you have any questions, you can contact me, and I can talk with you, work with you by email, whatever works with your schedule. Hey, this is what I'm thinking of. Do you know where I can find this? Do you know somebody who has this expertise? How do I go about doing such and such? I spend a lot of time doing that as the main portion of my job. Happy to help. We also have a very active educational program, and we've kind of divided it into two groups. One, our first group is the degree granting and career development. So this is a competitive program where you need to put in an application and be accepted and to move forward in these. We have a T1 predoctoral, and that's similar to a T32 program. Our KL2 program, this is a much longer one, up to 5 years in length. This provides a lot of intensive mentoring of research, and with the goal of having you put out R01s by the end of that. Then there's a tuition support fellows program. This is to get you MS or MPH degree in epidemiology or health services with that. Yeah.
Have you had any success, especially the column on the left, with any surgeons doing either one of those programs?
With the KL2, I believe we did have, I'm trying to think about the different people. I believe we have had a surgeon go through that.
The Department of Surgery has quite the setup for this.
But they, okay, in
But
the
it's
context of their 2 years of research.
But it's you're thinking of it in terms of like protected time?
Yeah,
'Cause
or,
an
you
issue.
know, for junior faculty members, or, you know, residents, you know, I'm wondering what that, you know, depends on what the setup is.
It hasn't been, from the Department of Surgery side, it's not been residents.
Oh,
It's
okay.
been people that have come in after fellowship to specifically train. I think Dave Wong's group, Source, Scope, that group,
Okay.
I know use this quite a bit, but, and they have their own support as well in their own program.
But I can also look, if you're interested, I can also delve into whether or not the KL2s are, how many of them are
Yeah.
surgery and kind of, you know, move forward from that. So there's a wide range, 'cause it comes from all the different health sciences schools, so it's not just the School of Medicine that
Right.
become KL2 scholars, so. And then separate from that, we have a lot of education and training that's available to anyone. So these are seminars that we have that we tape and that you can then go back and watch at any time online there on our website, which is really helpful. A lot of groups actually use this for training. They set up a curriculum for their fellows or even their research staff and use these as part of the training. We have a clinical research education series. This is more for kind of support staff with doing clinical education, how to do write up, how to do finding patients, working with patients, dealing with IND applications, things like that. Our career development series is for young faculty or fellows, deals with topics like what are the different kinds of K awards that are out there? What's the best, when you're going out for a job, how do you then negotiate for your position? What are other things that you need to know in terms of asking for, in terms of positions and things? We also offer Red Cap classes. We've had a great grant writing workshop earlier this fall, and we've also had different comparative effectiveness training events that have gone on. So again, these are available online on our website if you don't come in real time, and they're free. And then funding, we have a few funding mechanisms that we ourselves support. We also have managed other divisions' funding. For example, we managed an anesthesiology where we have provided the reviewers for them, but the money actually comes from them. But these are our funded ones. We have a small pilot project grant that's $10,000, and it's offered twice a year. We just finished up our fall call, and I don't know when our spring call will be coming up with that. So that supports small pilots in all areas of translational science. So if we've done bench, we've done comparative effectiveness, and we've done everything in between with that. Our community partners in research, this is for a community group that wants to pair with an academic to move their research forward. For example, advantage of this would be one of the Hispanic groups in the region in Yakima. Just wanted to learn more about how to work with diabetes in their own community, have hooked up with one of our academics and have put a grant forward. And then Ignition Awards for our preclinical research, and this is given through the Primate Center and also through the pharmacy school. So I just wanted to, this is the final slide, I just wanted to emphasize about planning ahead. It's kind of like dealing with OSP in a way, especially for things if you're interested in doing, in using our biostatistical group. You really need to think ahead. I've had people call me 2 days before their grant is due and say they want to have someone look over their study plan to see if it works out. That's not going to happen. They have a lot of business, and if you had come 6 weeks earlier, gotten in the queue, they could have easily worked with you and helped you with that. Not all groups are like that, but I did want to point that out because that is a very popular one that we have. I also do provide letters of support, and I'm the contact for that as well. And if there's any just kind of general questions that you have, big or little, I'd be happy to answer any questions. And I also want to say that almost all of our courses, in fact all of them, do have a portion of free consulting time. So it's not like that if you pick up the phone and call them that they're going to be like, oh, you know, the clock is ticking or so on that. So that a lot of them they'll want to hear what you have to say and see if they can help you before kind of going through and starting to charge in that. So don't feel that you can't reach out to them before you do that. Are there any questions? Yeah.
Do residents have student status? So can they come to ITHS as trainees as opposed to, how are they treated as their status within ITHS?
We used to have a membership where there was kind of a
Right.
student and and we're phasing that out.
Okay.
So it's not a detriment or or an issue or anything like that.
Thank you very much indeed. I think you can see that there's a really rich infrastructure here. And one point I want to make is that although most of them are pay-for-play services after the initial contact, you can use your resident research grant to pay ITHS. So if you think you're going to need, supposing you want a research coordinator who could find 20 subjects for you and administer a certain protocol on them, and you know that you're not going to have time to do that, then you can, in your resident research grant, put money in for an ITH coordinator, and we can just, you can just pay ITHS directly yourself. So that gives you some financial leverage there. And also, include us in your planning budget there. When you write, let's say, an OREF grant, it will not only be to your benefit to show that you have all of these resources behind you to convince the reviewer that you're going to be able to get your research done, but it will also be important for you to include a budget item in the grant that will help pay for those resources. So it's really accessible to you. Even though it's pay for play for the most part, you can find resources which you can use to use these great services.
And also, I would add to that you're working with different groups, that if you need verbiage for budget justification or anything like that, that they can provide that specific, you want something targeted towards something, they can give that to you.
And isn't it the case that, for example, supposing you needed a power analysis for your power calculation for your grant proposal, as long as ITHS is in the budget, is it true that they will provide such services at no cost?
It's not at no cost. So if you write in a statistician, I think you get a greater number of free hours,
Got it.
but
Okay.
it wouldn't be free.
Not free, but there are ways to extend your access.
And that's why it's helpful to start early and then figure out kind of where you are, because then that can give you more time with that and planning.
Good. Okay, so it's there for you. Make use of it. Thank you very much indeed.